Welcome to Billing and Coding for the VA Provider. The objective of this presentation is to introduce students and residents to billing and coding while you are doing your rotation at the VA. Formal medical education programs such as PA programs, med schools, and NP programs often provide us with the knowledge to diagnose and treat patients, but fail to adequately explain the importance of billing and coding. Billing and coding allows providers to collect revenue for the services provided. In this course, we're going to review the components of a history and physical exam. We're going to discuss the elements of medical decision making. We're going to provide an overview of coding. We're going to attempt to explain the amount of documentation that's needed to support the appropriate code. And we're going to introduce to you the concept of risk stratification. History and physical exam is made up of several components. There's the chief complaint, the HPI, the review of systems, the social history, the past medical history, medications, allergies. Then we'll include your physical exam and then a database of information that you're using during that encounter to make your decisions. And finally, your assessment and plan. So let's go through a typical encounter. What are you going to do and what are the steps? Well, the first thing you're going to do is you're going to review a chart before you go in and see your patient. Then you're going to go in and speak with your patient and perform your physical exam. Then you're going to meet with your team and decide what the appropriate next steps are. You're going to review any studies that you've ordered. And then finally, you're going to document. Why do we document? Well, first and foremost is to communicate with other health professionals. Depending on what service you are working on at the time, you will need to record your information in order for someone else to look at it. Medical legal, if you didn't document it, you didn't do it. You've heard this a million times. You're going to continue to hear this. And finally, it allows for billing. So how does a provider get paid? How do you take this encounter and turn it into this encounter? Well, when you graduate and you become gainfully employed, you may have a salary that's based on a set wage, but then there also may be what we call productivity pay, which is going to be based on how productive you are. And that's where billing and coding comes in. So basically, this is a return on your investment. Doing charting well and allowing for good billing basically is a return on the investment of your education. In the VA system, our billing and coding affects the budget, which allows us to provide care for our veterans. So for the most part, you guys know what's going on in terms of the cycle. You get a history, you do a physical exam, you interpret the data that you've ordered, whether it be labs or radiology studies. You do medical decision making, and then finally you document, which leads to coding. So what reimbursement is taking your documentation, turning it into code, which eventually turns into reimbursement for your employer. From your standpoint, think of this as all the time and effort you have committed to yourself in terms of your education. Your patient ultimately gets the benefit of that, and you should receive a return on your investment. You are, however, up against a coder, and basically you need to have certain criteria and certain elements in your note in order to satisfy for reimbursement. In the VA system, only 25% of our encounters are actually reviewed by coders, so it's incumbent upon us to do this accurately. This presentation is based on the Evaluation and Management Service Guide. There has been some updates in the past few years. The newest update is much less. There's been some significant changes. However, if you find the 2016 Evaluation and Management Service Guide, there is some great examples of how to structure your notes. So let's break down the process. Think of the complexity of a problem. Let's take the first one, a 24-year-old female with no significant past medical history who presents to your clinic because they have an insect bite, versus a 74-year-old with a history of coronary artery disease, diabetes, peripheral vascular disease, who's presenting with fever, chills, right leg pain, and swelling. When you think about it, how much time and effort would the first case take versus the second? So coding comes down to 5 levels. Levels 1 through 3 are minor problems, or what we consider problem-focused complaints and examinations. Our level 4s and 5s are complex complaints and with multiple comorbidities. What factors determine the coding level that you need? Well, it depends on how complex the problem is. It depends on whether it's a new or an existing problem. How complex is the data that you need to look at during that encounter? How much time you spend with the patient? How much time you spend reviewing old medical records? And what's the risk that the patient is going to get sicker? So here's some basic examples of levels. A level 1 is a very simple encounter. It's usually a nurse-only encounter for a medication refill. Level 2, a simple orthopedic injury in a healthy person. A level 3, a cellulitis in a diabetic patient is going to be treated as an outpatient with oral antibiotics. A level 4, an admission for a planned cholecystectomy. And finally, your sick patients, which you'll see a lot of at the VA system. Somebody who has a history of hypertension, diabetes, congestive heart failure, who's presenting with an acute MI. And essentially what it comes down to is the higher the level of coding, the higher level of the reimbursement. There's been some significant changes this year. Previously, there was a required number of elements of history of present illness. You had to have a certain number of elements of the review of systems, a certain number of elements for PMH, family and social history, and a certain number of elements in the exam in order to meet criteria for higher levels of coding. That is no longer the case. According to the Valuation and Management Service Guide, what is required is sufficient documentation to support your medical decision making. Previously, we needed to include 1 to 3 elements of an HPI for a level 3 exam, and for level 4s and 5s, which are your detailed and comprehensive, you needed 4 or more. Same with review of systems. It used to be the biggest reason charts were down coded is that for a level 5 complete examination, you needed 10 or more elements of a review of system. We no longer have to subscribe to that. So the new requirements look at medical decision making as straightforward, low complexity, moderate complexity, and high complexity. There is essentially no longer a level 1. It's basically that is encounters that don't require a licensed medical provider. So what are the 3 components that make up evaluation and management? Well, the first is the history, which includes the chief complaint, the HPI, the review of systems, and past history, and the social history. Then there's the physical exam. And then finally, there's medical decision making, which has 3 components: the number of diagnosis, the amount of data you're looking at, and what's the risk that the patient's going to become sicker. So you always want to start with the medical decision making, because this will save you time in the long run. You want to consider how much time and effort that you're going to need to put into your exam and your note. So this way it will save you time at the end of the day when you're charting, because you don't need an extensive write-up for someone with a simple bug bite who's otherwise healthy. So basically, if you thought your day in an emergency department was going to look like this, the reality is that you're going to spend a lot of time on the computer doing your charting. So medical decision-making comes down to the number of diagnosis and treatment options, the complexity of the data that you need to look at, and finally, the risk that the patient is going to become sicker. So that's the components of medical decision-making. So let's review what's in a note. First of all, you're going to start with a chief complaint, a concise statement describing the symptoms or problems that the patient is going to come in for. Every emergency department note should start with a chief complaint. It may not reflect where you finish, but with the encounter, but it starts with why the patient comes in. And whenever possible, it should be recorded in the patient's own words, and it's the foundation of the medical necessity. Then you have your 8 elements of your HPI. You have your 14 elements of the review of systems. Then you have your past history, your family history, your social history, which may be pertinent. And here's an example out of the EM guide of some examples of family history. And finally, your physical exam, which can be done by either body areas or organ systems. As I mentioned earlier, the prior evaluation and management service guides have some great examples of how to do notes if you're still wondering what should be included. So these are just some examples of what's included in these examples. If you go back and go to the CMS website, you'll find that. So in terms of medical decision making, again, what is in there? The number of diagnoses, the number of treatment options, the complexity of the record you're looking at, and finally, what's the risk that the patient is going to become sicker? So what you're going to need to explain in your medical decision making part of your note is the complexity of what you're doing and how you came to your decision. So your assessment and plan should include what you're doing and what you're thinking. One of the biggest mistakes, or not so much mistakes that students make, but one of the more common things that students tend to do is just recapitulate the HPI. And that's not what we're looking for. We're looking for what the problem is and what you're going to do to fix it. So for someone who has an established diagnosis such as diabetes, you're going to need to tell us whether this is well controlled, if it's not well controlled, why it's not well controlled, and what can be done moving forward. If you have a new diagnosis, such as you're ruling out, acute coronary syndrome, you can include that as your assessment and explain what's going on there. You need to explain how you got to your conclusions and explain what you've looked at and what you've done, whether you've looked at old medical records and gleaned information from that. If you have a new finding on a lab test, someone has a new acute kidney injury, you may review, what their baseline renal function is and what the problem is today. And if you're doing your own interpretation of an X-ray or an EKG, you should include that as well. Simple notations such as an elevated WBC is sufficient, that the chest X-ray was unremarkable. If you're getting information on collateral from family members, you should document that as well. In terms of documenting the risks of morbidity and mortality, you should include that. If your intervention is for a surgical procedure or an invasive diagnostic test, you need to explain the risks of that. So basically, you're going to need to lay out the level of risks. If someone has underlying cardiovascular disease, if you're planning an invasive surgical procedure or an invasive diagnostic procedure, what are the risks to the patients, and indicate that you've discussed that. So in terms of medical decision-making, it again comes down to whether it's straightforward, low complexity, moderate complexity, or high complexity. And again, it's based on how many diagnosis or management options, how much data you need to look at, and again, what's the risk that the patient's going to become sicker. In terms of evaluating risk, one of the best tools that's out there is MD Calc. It will help you as a new provider assess some of the risk that's there. So I would recommend that you have this either on your desktop or on your phone. So let's talk about the level of risk. What's minimal risk? Well, in terms of the diagnosis, it's one self-limiting or minor problem, a viral URI, an insect bite, a rash. If the diagnostic procedure is simple, such as non-invasive chest X-rays, EKGs, urinalysis, or if your management options are simple as well, rest, garlic, superficial dressings, that's considered minimal risk. Low risk is 2 or more self-limiting or minor problems, or 1 stable chronic illness, diabetes, hypertension, or if you have an acute uncomplicated illness, such as a cystitis or a sprained ankle, that's where you're going to find the low risk. In terms of your diagnostic procedures that can increase the risk, skin biopsies, superficial needle biopsies, clinical labs requiring arterial puncture, ABGs. If your management options are over-the-counter medications, physical therapy, again, those are all considered low risks, along with IV fluids without additives. Moderate risks, presenting problems, 1 or more chronic illness with a mild exacerbation, 2 or more stable illnesses. If you have an undiagnosed new problem, or an acute illness with systemic symptoms, this is considered moderate risk. In terms of your diagnostic procedures, again, they can have risk if you're obtaining bodily fluids, such as doing an LP, a paracentesis, a thoracentesis, that is considered a moderate risk. Or if you're adding IV additives to your IV fluids, that's also considered a moderate risk. And finally, high risk, 1 or more chronic illnesses with severe exacerbation, an abrupt change in neurologic status. If your diagnostic procedures are more invasive, then that's considered high risk. Or if you're moving on to surgery, especially emergency surgery, those are considered high risk. So under the new guidelines, there really is not a level 1 in an inpatient hospital setting, such as an emergency department. And again, a quick summary of low, moderate, and high risks are on this table. To help you understand how to calculate medical decision making, we're going to walk through an exercise in coding. We're going to create a table to calculate the risks, the data, and the diagnosis. So the maximum number of points for any one category is going to be 4. So it's very simple to get to 4 points. So for every clinical lab value that you order, you get 1 point. If you're doing your own interpretation, you get 2 points. So you'll table it out 1 through 4. In terms of the diagnosis, if it's a new or self-limiting problem, such as a rash or a sore throat, you get 1 point. If you have a number of well-established, well-controlled problems, it's a number of problems times a number of 1. So again, easy to get to 4. If you have a new problem with no planned workup, it's 3. If you have a new problem with a workup, it's 4. Again, very easy to get to level 4. And then finally, it will help you determine your complexity of your medical decision making, whether it's straightforward, low complexity, moderate complexity, or high complexity. So what we're going to do is we're going to tally up the results in each column. We're going to take the lowest of the 2 highest. This is how the EM guide defines this. So let's walk through a case. So let's start with this guy. He's a 75-year-old guy who presents to your clinic with a history of COPD. He's got a 3-day history of worsening shortness of breath, dyspnea, and exertion. He hasn't been vaccinated for COVID. He has oxygen, which he usually uses at night. He's using it all day. He's had no improvement with his inhaler. He describes a cough with thick green sputum. He feels warm, but he hasn't taken his temperature. He's a former smoker, but has a 60-pack year history. You get his vital signs, and you notice that he's tachycardic, he's tachypnic, he's hypoxic, and he's got a low-grade temp. So you get some information on him, and you get a chest x-ray, which looks like he has bilateral lower infiltrates. He's working to breathe, so you get a gas on him, which is showing he's acidotic, he's hypoxic, and he's retaining. You grab an EKG, which shows he's got a strain pattern. So what do you have in summary? You have a 65-year-old guy that you're going to admit for severe COPD exacerbation. He's got a new pneumonia, a new oxygen requirement, and you may believe he may end up on a ventilator. So we've got severe respiratory distress. You've looked at a number of data. You've got chest x-ray, EKG labs, and then you've got a new diagnosis, which is the pneumonia with several other existing poorly controlled issues. You pull out your MD calc, you do a port score on him, and this hospitalization alone, he has an 8 to 9% chance of mortality. So what do we have in terms of risk? He's got a high risk based on MD calc. You've had a lot of data to look at. You've got enough diagnosis for a 4, lowest of the 2 highest. It's level 5, high medical decision making. So under the old system, you would have to do a history with 4 elements of an HPI. You'd have to do an exam with 9 elements in order to satisfy that. That's no longer required. You don't have to worry about counting up your HPI elements or review of system elements. That goes away. So what you do have to include, and again, the old system, you would have to have 9 body systems area. Again, all of that went away. What you do want to include in your assessment plan of what your diagnosis is, it's an acute respiratory distress with hypoxia. You have an abnormal ABG, you have abnormal vital signs, you have a normal EKG, you've put them on BiPAP. You got COPD exacerbation, you're giving them steroids, nebulizers, you got pneumonia, you're starting antibiotics. You've looked up your ICD-10 diagnostic codes for this. So what is your assessment plan? It's what are the problems and what have you done to fix them? So if your assessment plan that, someone that comes in to see you just needs to do lifestyle modifications, you're going to document that. If you're recommending medications, you're going to include what you're doing there. If you're recommending a surgical intervention, you'll include that. Your assessment plan should list out each of the problems that you have identified at that visit and what you're planning to do with it. It not only provides effective communication for other specialists, it's also going to enhance your billing, especially if you're doing your own billing. And if you've ended up ordering a study that isn't quite apparent of why you got there or how you devised that you needed it, that's where you're going to include it. So let's walk through a second case. You've got a 36-year-old guy with a history of alcohol dependence who's coming in with abdominal pain, nausea, and vomiting for 2 days. He tells you he's been on a bit of a bender, drinking a pint of vodka daily for the past 3 months, but has no other medical complaints. You do your exam, you get some data, You get some labs. He's got elevated amylase and lipase. So you diagnose him with pancreatitis. It's a new diagnosis, but you don't feel like he needs any additional imaging. You're going to treat him with a banana bag, some pain control, an antiemetic, and there's no additional workup. You calculate his Ranson criteria and you come up with only 2 points, so a 1% chance of predicted mortality, which you might think makes this a low risk case. However, it ends up being a moderate risk, and we're going to explain in a minute how we got there. You've got data, which is basically labs. You've got diagnosis, which is a new problem with no additional workup. Lowest of the two highest makes it a moderate medical decision making. And what makes it moderate? Well, you have a new illness with systemic symptoms, and you've given him IV fluids with additives. So what's your assessment plan for this individual? Assessment is abdominal pain, acute pancreatitis, alcohol dependency. You've looked up your ICD-10 codes on this. You're going to recommend bowel rest, IV hydration, correct any electrolyte derangement. You're going to control his pain, and you're going to monitor for withdrawal. If the risk is the lowest of all of your medical decision-making components, review your information. It's possible you may be ordering way too much stuff that's not going to get reimbursed, so you need to be careful of that. In 2022, there was a change on how office encounter or outpatient encounters could be coded. They could still be done by using the medical decision-making model, but it also could be done by time, and the time is calculated in 15-minute increments. And what's included in the time is anything that is done on the day of service, whether it is reviewing the charts, obtaining the history, performing the exam, speaking with the family members, ordering tests, conferring with other providers, documenting, basically writing up your notes, and doing any care coordination. What this allows for is to account for patients who require additional time for low-risk medical issues, especially with social service issues. So for new patients, anything up to 29 minutes is a level 2. For an established patient, anything between 10 and 19 minutes is considered a level 2. A level 3 on an established patient is 20 to 29 minutes. A level 4 on an established patient is 30 to 39 minutes. And for a level 5 on an established patient, it's 40 to 54 minutes. There is also a procedure code that can be entered if there is additional time exceeding 60 minutes, and it's also given in 15 minutes increments. The only requirement is that you document on your note a text that indicates how much time you spent with the patient. Now, this is useful for outpatient encounters. It's also useful for hospital consultations. So in summary, the new changes for using time is you could either do the medical decision-making model or time spent, and it's all of the efforts that you make that day on the day of service. And what this allows for is increased RVUs, especially on patients who require additional time. In terms of revenue value units, most medical students don't have a great understanding of what an RVU is. And that's how the Medicare and Medicaid services reimburses hospitals and medical practices for their services. And it's basically a value system. And there's also a capture for CPT or procedural codes. So if you're doing a procedure on a patient, there is a code for that. And the RVUs rank the resources. So essentially, if you're doing a simple procedure, it's a low RVU. If you're doing a more complex procedure, the level could go up. So a service that requires 6 RVUs means that the resources consumed are 6 times greater than those consumed by procedure code with a level 1. So why is this important? Well, when we do our coding level, 1 through 5, what this turns out to is that there's an associated RVU value. So there is an incentive to try to document at the highest code in order to maximize your RVUs. For procedure codes, there is a value that can be assigned, something as simple as a unilateral cerumen removal is a 0.47, but if you're doing a more extensive surgical procedure like a mastoid clean out, it's 2.4 RVUs, or a surgical procedure for ear canal surgery, it's 31 RVUs because it's much more intensive and resource demanding. You can also get procedure codes for drawing blood, interpreting EKGs, giving fluids, performing procedures such as suturing, incision, and draining, and also doing ultrasound guided diagnostics and procedures. So there's different types of RVUs. So there's work RVUs, which accounts for what you're doing with billing and coding and procedures. Then there's practice RVUs, which kind of accounts for the overhead. And finally, there's RVUs that accounts for malpractice. And then there's a geographic factor that's built in to stabilize payments and account for higher areas of cost of living. So for example, in Manhattan, there's higher work RVU codes versus Beaumont, Montana, which has a lower RVU code. So if you want to know how to calculate an RVU code, which is useful if any of your compensation is based on RVUs, you need to account for the work code, the malpractice code, and with a differential for the area that you work in. So what does this actually mean? It means that any work that you performed, your overhead, such as hospital costs, then your malpractice with a factor that allows for whatever geographic area that you are in. Then it's put through a conversion factor to stabilize it, especially in areas from year to year when you have areas of high inflation, it stabilizes the payment. So basically an RVU is the work with a geographic factor built in, the overhead with a geographic factor built in, which is practice environment, malpractice costs with a geographic environment multiplied by a factor to account for inflation. And that's how you calculate RVUs. So in summary, in terms of documentation, you want to basically make sure that you're documenting accurately. And if your documentation doesn't support the code that you're trying to code for, it's going to be reduced or denied. If you do extensive write-ups or you order a lot of tests thinking that you can upcode your chart, that's not going to work for you either. Ordering a lot of tests for a minor problem or procedure is not going to be reimbursed. So you want to make sure that you're ordering appropriate tests and also documenting appropriately. From an insurer standpoint, they need to see where the service is done, that it's medically necessary, and that it's appropriate testing. Just because your practice has a CAT scan or an MRI does not mean everyone needs that test. So in terms of documenting, you need to indicate the rationale for what you're ordering. You need to be able to assess what's going on, and that should be communicated to someone else, and identify the risk factors for the patient. So understand that documentation and billing is ultimately your responsibility. And if an error is made, it is considered fraud, even if it was without intent. So in terms of charting, every chart should be bulletproof. You want to make it non-judgmental. Remember what you write today, you're going to be reading back in court tomorrow. Remember that most electronic health records are now able to be viewed by the patient. So if you are saying something unflattering, it's going to be read by the patient. Make sure that you address all the complaints, justify what you're doing in terms of your billing and diagnosis, and make sure you look at other providers' notes, such as the nurse's note, to make sure you're addressing anything that could be brought up there. In terms of your documentation, think of the worst case scenario and provide documentation that you considered it and ruled it out. Avoid dangerous words such as malingering, and avoid anything that could be viewed as judgmental. In terms of your discharge, let the patient know what their diagnosis is, what they need to do about it, and what they need to return for. And finally, never alter a chart after the fact. If you need to make changes or correct something, do it as an addendum. So your take-home points, it's still better to over-document than under-document. Consider the time you're spending with the patient when you document for coding. Provide a clear rationalization of what you're ordering and why, and always be professional. Thank you.